Correcting a life-threatening fetal defect immediately triggers a secondary cardiovascular crisis. The closure of a patent ductus arteriosus in extremely premature neonates forces the heart to rapidly adapt to a violently altered circulatory environment. Prior to surgery, the infant exists in a state of chronic ductal steal. The open vessel creates a high-output, low-resistance system, allowing the premature heart to pump massive volumes of blood with minimal. To correct this, the surgeon accesses the chest cavity through a posterolateral thoracotomy and places a physical clip across the ductus arteriosus. The moment that clip closes, the ductal steal abruptly ends. This sends a massive, invisible shockwave of pressure rebounding directly into the aorta and straight back into a functionally immature left ventricle. By eliminating the risk of pulmonary overcirculation, the surgery instantly introduces a life-threatening spike in left ventricular afterload. This places immediate, unsustainable strain on the heart's ability to pump. Moving the patient from the operating room to the bedside, the resulting cardiovascular instability follows a precise, predictable sequence of mechanical and endocrine failures. The primary overarching threat is post-ligation cardiac syndrome, or PLCS. This syndrome manifests as a rapid cascade of oxygenation failure, ventilatory collapse, and profound systemic hypotension. The infants most susceptible to this rapid collapse share specific risk factors. First, extreme prematurity, a birth weight under 1 kilogram, and an unusually large preoperative PDA. In this clinical scenario, standard resuscitation instincts fail. Treating postoperative hypotension in these specific neonates with aggressive fluid boluses compounds the crisis. The heart is already straining against immense pressure. Adding volume overloads a failing pump. Survival relies on abandoning generic resuscitation habits. The clinical team must anticipate and intercept highly specific, time-bound physiological failures. This flowchart maps the exact pathophysiology of post-ligation hemodynamics. Immediately after the surgical clip is applied, the left ventricle faces an enormous spike in exposed afterload. This forces the ventricle to fail along 2 distinct mechanical pathways. Tracking the left branch of the diagram, the sudden resistance induces systolic impairment. The extremely premature myocardium lacks the muscle mass and contractility required to push against the new systemic pressure. This weakened contraction immediately reduces the stroke volume of each heartbeat, severely depressing total left ventricular output. The clinical endpoint of this systolic cascade is a precipitous crash in systemic arterial pressure, plunging the neonate into cardiogenic shock. Simultaneously, following the right branch of the flowchart, the afterload spike triggers diastolic impairment. The overworked ventricular wall becomes stiff, failing to relax properly between contractions. This stiffness creates a mechanical bottleneck. Left atrial pressure builds and forces blood backward, aggressively spiking pulmonary venous pressure. The clinical endpoint of this diastolic failure is rapid pulmonary edema. Fluid floods the alveoli, lung compliance plummets, and severe hypoxia sets in. Managing the postoperative neonate requires fighting a simultaneous 2-front war: systemic circulatory shock driven by systolic failure, alongside pulmonary flooding caused by diastolic failure. This clinical pathway details the phased interventions required to manage these mechanics. The first block marks the 0 to 2 hour window post-surgery, the critical timeframe for preemptive stabilization. As lung compliance shifts following ligation, respiratory settings require immediate adjustment. Clinicians must decrease mean airway pressure, the average pressure exerted on the lungs during a breathing cycle, to reduce intrathoracic resistance and facilitate venous blood return to the right side of the heart. Fluid management in this phase operates under a strict rule of euvolemia. Maintaining exactly the normal volume of blood for the infant's age is required, avoiding both aggressive fluid restriction and diuretic therapy. The gold standard for cardiac assessment in this early window is targeted neonatal echocardiography, or TNECHO. This point-of-care ultrasound directly measures the exact left ventricular output. If the TNECHO detects that output has fallen below 200 milliliters per kilogram per minute, specific pharmacological action is taken. The infant receives prophylactic milrinone, an intravenous medication that dilates blood vessels to reduce afterload, while simultaneously strengthening the heart's contraction. Leveraging targeted echocardiograms and early milrinone administration proactively disarms the afterload pressure spike, before full-blown PLCS can manifest. This graph tracks arterial pressure over time following the duct ligation. Focusing on curve B, early hypotension, a severe drop in both systolic and diastolic pressure, frequently occurs between 2 and 4 hours post-operation. The mechanical afterload is not the primary driver of this specific crash. Instead, it is caused by adrenal hypoperfusion, a lingering effect of the chronic ductal steal that starved the adrenal glands of blood flow prior to surgery. Because the extremely premature infant relies on a developmentally immature hypothalamic pituitary adrenal axis, the body is physically incapable of mounting an adequate cortisol response to survive the intense surgical stress. Returning to the clinical pathway, the intervention for this distinct adrenal failure is clearly mapped. Hydrocortisone is the first-line medical defense to restore vascular tone, not a volume-loading bolus. The protocol adapts to the specific nature of the pressure drop. If the systolic pressure fails, dobutamine is added to support cardiac contractility. A normal saline bolus is considered cautiously only if the diastolic pressure is the predominant failure point. Shifting focus to the 4 to 12-hour window, curve A marks the traditional onset timeline for post-ligation cardiac syndrome. This curve represents the left heart reaching total exhaustion. It is characterized by a progressive, grinding decline in systolic pressure, combined with simultaneous oxygenation and ventilatory failure. The flowchart dictates aggressive inotropic escalation during this phase. Clinicians start with dobutamine, but quickly escalate to epinephrine to chemically force the failing ventricle to contract. The pathway includes a defined safety net. If the hypotension becomes refractory or continues progressing despite epinephrine, hydrocortisone is added to combat any underlying adrenal insufficiency. Contrast these hypotensive crashes with curve C, representing postoperative hypertension. Sustained high mean and diastolic arterial pressure, paired with a normal pulse pressure, guarantees severe pulmonary edema and requires immediate diuretic treatment. Precisely mapping the post-operative timeline to these distinct pressure curves equips the clinical team to accurately distinguish a failing endocrine system at hour 3 from a collapsing left ventricle at hour 8. Beyond systemic hemodynamics, the surgical approach carries isolated anatomical risks. The posterolateral thoracotomy puts the left recurrent laryngeal nerve directly in the surgical field. Because this nerve loops immediately adjacent to the ductus arteriosus, the physical manipulation required to place the clip makes the nerve highly susceptible to extreme stretching, neuropraxia, or being completely severed. Post-operative nursing assessments must target this specific peripheral nerve damage. Staff monitor relentlessly for secondary signs, like new feeding issues, audible airway stridor, a hoarse cry, or unexplained drops in oxygen saturation. Up to 30, this high prevalence demands targeted clinical follow-up before discharge, heavily relying on awake flexible nasal endoscopy or vocal ultrasound to verify airway safety. Exceptional intensive care integrates these peripheral assessments, prioritizing intact airway reflexes and swallowing mechanics alongside cardiovascular stability. Successfully managing extreme premature neonates post-PDA ligation requires abandoning generic resuscitation protocols and symptom chasing altogether. Pushing standard fluid volume into an infant suffering from a stiff, failing left ventricle directly accelerates pulmonary edema and deepens hypoxia, compounding the exact mechanical failures triggered by the surgery. The neonatal ICU nurse serves as the frontline analytical defense, tasked with recognizing distinct time-bound physiological phases to advocate for precise, targeted medical interventions. High-quality care relies entirely on understanding the specific mechanical and endocrine forces driving the shock. Only by mapping the exact pathophysiology can the medical team stabilize the system before the symptoms prove fatal.